Hi everybody, I'm just going to take control of the slides here. Right, so as Sandra's just mentioned, my name is Julie Cracknell. I'm here to talk about a project that we've been running in Swindon for about the last 18 months now. I want to thank Sandra because this is the second bite of the cherry that she's given me. I was meant to sort of present last year, but unfortunately I got struck down with COVID, so couldn't. But I really wanted to talk about what we've been doing in terms of improving quality in cancer care reviews and embedding personalised care into those. It's a 2-year project that has been funded by Macmillan, but I also hold an additional role as a practice nurse in the local area. So the project really came about because we had some issues in the area with regards to the quality of cancer care reviews that were happening. Also, some inequalities that we experienced in the local area. So the scoping exercise was sort of done by the Macmillan GP, who's on the call today, Karen Sandhu, and the Cancer Projects Coordinator for the ICB, Cherry Jones. So we involved the local partnership manager from Macmillan for the area, and they really drilled down into some of the specific area challenges when we were looking at personalised care, but with a primary care hat on. So from there, they developed what the issues were in the area, which was a lot of area inequalities. It's Swindon is a very difficult area it's statistically because it's regarded as being a nice area to live in, but actually we've got these pockets of deprivation, and we've got some groups of BAME and LD people. So we really need to sort of make cancer care reviews accessible to all. Also, from some case studies that were run across the area, we knew that some of the cancer care reviews were a tick box exercise, and that they were happening more opportunistically instead of being pre-planned. Obviously, the problem with that is that the patient doesn't have a chance to sort of think about what they want to talk about at the review, and it's just sort of launched upon them. So we knew that was a problem. We also knew that the patients sort of perceived the gap between secondary care and primary care as being a problem because they felt like they were being dropped off the edge of a cliff after they've had some treatment. We also knew that there was a lack of training and support for our primary care clinicians, and they weren't confident in conducting cancer care reviews. And all of these problems together were leaving people who did have a cancer diagnosis with some unmet needs. So that really wasn't good enough. So from all of those challenges, we developed our opportunities, which were we needed to address the quality of CCRs taking place in the area, reducing unmet needs, and as a result of that, additional GP contacts. We needed to promote the use of the templates, which provide structure to the reviews. We also needed to collaborate with secondary care and third sectors. We needed to provide education and support for our primary care clinicians. We really need to push the structure of CCRs. We also needed to signpost our patients to services that we're running in the area that perhaps wasn't aware of. Increased holistic assessments, so moving from a medical model to more of a holistic health and well-being model for the patients, and as a result of the end of the project is create some ongoing support and networks after the project's finished. So really what we want to do throughout the project is increase the quality of life for people in recovery from a cancer diagnosis and provide education and support. By doing this, we know that there is benefit to patient because it helps them in their recovery by doing all the things that I've just highlighted, and to live better with cancer. But we also know that there are practice and clinician benefits because it helps build their confidence and networking across local services. And we do that by providing training and support documentation, and really embedding some structure into the reviews. So it was really develop some work streams going forward. So we really were working on how can we make it easier for our primary care colleagues to engage with us and to engage with the patients. So we knew that by going in and saying this is how it should be done really wasn't going to work. So we needed to make things easier for primary care in terms of creating some structure and documentation. So what we did was create a standard operating protocol for them. It's basically a flow chart that says this is how your cancer care should be structured, booked. There is some safety netting and verbal prompts for the booking teams, because one of the things that we were finding when we were going out and visit practices is that the people who were non-clinically trained were very nervous in contacting people and booking people in. So we've created some verbal prompts to instigate that conversation to happen. The standard operating protocol also includes safety netting, so it was unclear how we were to safety net the people who perhaps didn't respond to an invitation, and or even those who didn't attend. And also by doing that, we looked at what barriers there were for people to attend. So by creating a work stream in terms of the booking of an appointment, that person who picks up the phone and books that patient in has got an opportunity to find out whether that person's got some challenges. So, have they got visual or hearing impairments? Do they need an interpreter? Do they need to attend with a family member or a support worker? So making those reviews really, really accessible for everybody to get into. And also moving from a position of when it started in COVID, from doing everything by telephone, really sort of getting people into the surgery again, and even actually in some cases going to their home and doing their cancer care review at their home. So by handing that SOP over to the surgeries, they were able to rebrand that, adopt that, pull it into their practice, and actually provide some evidence when there were perhaps to have a CQC inspection to say this is how we're doing things. So that SOP was endorsed by all of our partners. So we have a working group of steering board who anything that we adopt, develop is agreed by everybody that this is a useful thing to have. So we were looking at some of the inequalities in there. I did some webinar sessions in terms of providing information. So we really started at ground levels, really. So explaining what a cancer care review is, why it's important in primary care, and really trying to get people on board with the way of thinking of, right, we've got people who are living longer now. They're going to be coming back to you in primary care. We really need to help these people live better, get back to work, and support them more in primary care, and moving towards sort of a long-term condition frame of mind. I did some weekly virtual drop-in sessions, so anybody who were having any challenges could drop in on a Monday and just say, look, this has happened, how do we get over this, how do we do this? So what I did was every time I came across any barrier or challenge, I was going out and visiting surgeries. And every time anybody had a challenge, I was able to incorporate that into a support pack and really share that information to say, well, if one person's having this challenge, it's like the others are. So it was really an information sharing exercise as well. So we started to pull together a CCR support pack, which every time something needs updating in it, we can update, and it's shared out to each surgery. So that really supports the clinicians in doing their cancer care reviews. The training and education pathway, we knew that there were challenges because Macmillan did endorse the use of GPs, social prescribers, allied health professionals, practice nurses to do cancer care reviews. But we knew that there was no sort of national guidance on what makes you competent to do one. So that was a difficulty that we had to sort of take a logical view of, right, okay, this is what's available out there, pulling it together into a training pathway and then offering that out to our clinicians in primary care. and where people needed one-to-one help, I've been going out and visiting the practices. We pulled together a network of clinicians from each practice that are interested or are doing cancer care reviews, or indeed those people who aren't doing cancer care reviews but want to start upskilling. So we really got these people on board and getting the really sort of enthusiastic people who want to take that over on board to do the training. So in terms of the training and education, we've gone from a position of this is what's available out there, this is what we're endorsing or suggesting as a pathway, to right, we need to, we're putting too many people forward and these training courses are now oversubscribed, so we need to offer something ourselves. So we're sort of in the process now of putting something together where we're doing the training instead. So that's in development at the moment. We're getting some really, really good feedback from practices where they were, you know, perhaps were in the dark about what was actually required at a review. So we would go out and reiterate, this is what's required and this is the purpose of doing it. And we really were pushing the point of, if these people's needs are unmet, you're going to have repeat contact when it comes to primary care, because these needs will manifest in a different way. And we know from some past evidence that that's the case. We needed to sort of develop a reporting structure for what we were doing on the project, and the data was particularly difficult to try and interpret, because we started from a position of not being in the QOF framework for cancer care reviews, where it was a locally, each surgery would sign up locally to do them, but not every surgery was signed up, so that it was patchy which surgeries were and weren't doing it, how well they were doing them. So it was great from a position of, we'll get these people on board, but we didn't know how well they were being done. So we needed to really develop our reporting on the metrics originally, and then moving into the QOF framework, we now know, and it's more reliable in terms of how many are taking place. We still are working on the quality aspect though, because it's one thing having the quantity. Sorry, I think there was a noise there. So we now know we've got really, really good engagement across the area at the minute. We've got 96% engagement across all of the surgeries. Our patch has actually increased because we've got some geographic difficulties that I am employed by the ICB with the Macmillan Fund, but the surgeries that are covered cover the whole of Wiltshire, whereas my project is in Swindon. But we know that the hospital actually face different surgeries as well. So my patch has sort of increased in size, as it were. So that sort of adds a bit of difficulty when we're looking at numbers, but we have got really, really good engagement. We know as well where we've gone from is not knowing what the quality is at all, to now knowing through patient engagement and patient evaluation that we can now start acting upon what the patients perceive as the quality of a cancer care review. So the collaborative work stream has been really good. So as said at the very beginning, it was one of our objectives to work more closely with secondary care and third sector. So we've done that from the very beginning of the project. We have a steering group that's made up of Macmillan, myself, the ICB, secondary care, and some psychological services in the area, because we know that that's quite a large provision of what we need to do within cancer care reviews in the area. We know that working together has provided opportunities to network across the services, and we hold our steering group once a month and sort of decide where we need to go with each one. It's an opportunity as well to discuss any materials that we think might be useful and how well they could be implemented across secondary to primary care. An example of this is a handover pack when someone's finishing treatment. We know that there is this sort of perception of falling off a cliff. So one of the ideas that we've come up with is, when they've finished treatment, we need to start promoting cancer care reviews in the secondary care environment. So what a cancer care review is, and preparing people for the feeling that actually, yes, I've finished my treatment, and now I'm going into this phase of, yes, I'm going back to my GP surgery, but I know that there's something else there if I need it. So it's provision of information at the right times. So we're also working on really making our end of treatment summaries more consistent across all tumour sites, because when those documents come into primary care, sometimes they weren't recognised for what they were. So it's been made more clear now. It's an end of treatment summary, and the GP instruction is moved to the top of the document, so that they know what they need to do in GP land. The flip side of that is that we need to educate our primary care colleagues that when these documents come in, this is how you code them correctly, so that the clinician doing the cancer care review can get to that document straight away without having to wade through 20 different documents. So we are working more collaboratively in that respect. And one of the more successful things that we have done is working with the personalised care team at the hospital. So there is, we're quite lucky in Swindon. I know some areas don't have a personalised care team in their cancer teams, and it's made up of 2 CNSs, an occupational therapist, a physiotherapist, an admin resource, and we've got some psychological support as well. So we're aware of the provision in secondary care, what they can provide for patients, but that service isn't just available to people who are having treatment, it's available to people when they've finished treatment. So they know what we do. They also, we know what they do, but they also know what we do. And we have an opportunity at both ends of that to promote each other's service. So when someone comes in and they perhaps need help with fatigue, or help with, I don't know, sexual dysfunction, we know that they're running for virtual sessions on those things, and we can signpost that patient to that specific session. Or if they need help with recovery from a physical aspect, we know that they're providing prehab and rehab. So we know that we need to get these people into the right services at the right time. And we work very, very closely together in that respect. We also held a conference back in November, which was attended by primary care, secondary care, third sector, social care. It was really, really well attended. We were at capacity for the event. It was a really good event in terms of being able to network and talk about each other's services. So it was a very equal provision of information from everybody. It wasn't dominated by any one service. It was really strongly branded by Macmillan. And it was we had such good feedback because people just weren't aware of the provision that's doing. So an example of that was we described the role of a social prescriber, and as you know, as daft as it might sound, people just didn't know what breadth and depth of knowledge the social prescribers had and what they could do for people with cancer. And you know, after they've finished treatment, to be able to signpost directly to that service instead of going through 3 hops was much better. So we talked about each other's provision and what we could do for each other and how we could work more closely together. And that was really good. The strongest voice in the room was the one of the patient, and we were very lucky in that we had attendance from a lady in Swindon who was brave enough to share her journey at the conference, but she was also able to iterate how important it was that her journey was embedded with personalised care along the way. So she had such good provision of information, and she did know about the personalised care team, and she did know about the cancer care review, and she was signposted at the right time, which is fantastic. And we were able to capture her story on video, and the link is on the slide just there if you wanted to go on it and watch it. I didn't put it in today because it's a 6-minute video, but if you get a chance, go on and listen to her story. And it really brings the mood back to, the focus back to, this is why we're here. We're not here to tick a box or do this, do that. We're here to change the lives of people who've had a diagnosis of cancer and aid their recovery. So that was, from a strong point of view, that was really good to have that there. So moving sort of into more regional efforts now. I've been in post since October 21. We now have other people in post in Salisbury and in Bath who have come on board at a different time. We know that people in Oxfordshire, Berkshire and Buckinghamshire have come on board, and we're all personalised care nurse facilitators. So we're forming more of a network within the region now, and we are aligning what we do so that the messages that are given out are the same sort of messages. There might be locality sort of variations, but the themes are, and the evidence is, and everything sort of is a consistent message. And we all support each other as well, which is really good. I was very fortunate to make contact with Wendy, I'm sure she's on here today, who is from Kent Medway, and she took a different approach, or that team have taken a different approach to how they train people. So we've brought that into our sort of portfolio now, and moving ahead with that, because we weren't aware of that, but sharing that knowledge is really important, and the communication about cancer care reviews seemed to be really, really lacking. But it's now a really fast moving picture. So there's different things coming in from different areas. And what I'm keen to hear about from anybody is, if they've done all of this, they've embedded all this, what have you done next? What can we do that we can take from you? Can you give us some ideas? Where do we go from here, sort of thing? So our evaluation sort of work so far is that we know that we've had an increase in CCR numbers since the year before, which is really, really good. We know those numbers are going up. We know that the people who are interested in doing the training is steadily increasing, and it is a mixture of GPs, social prescribers, cancer support workers, practice nurses and AHPs. We know that we make referrals into secondary care, personalised care team from primary care. We're not capturing every referral because we know that some people self-refer, but for the ones that are made by clinicians, we know that that is steadily increasing as the months go on, which is really good. We also know that we've got really, really good practice engagement, and then that translates out to public. In terms of the feedback, we're getting very positive feedback, both from practices and from patients, because this is relatively new, what we're doing. But we know that we've got some quality work to do. And as mentioned previously, we've got some patient evaluations that are now going out after a cancer care review has happened. We're seeing them coming back. We're able to act on them. And they're not always positive, but it means that if someone's had an issue, it means that we can pick that issue up straight away. We can do some clinical learning, and we can change our practice as a result of that, which is really, really positive. We've learned some lessons along the way. COVID's been horrible for everybody. It's impacted this project like anybody else. Engagement in primary care is always a difficult thing to do, because it's always busy. There's always pressures. You can't approach people before just coming up to the end of QOF year, because everyone's so busy doing their QOF numbers. So we've learned from how we approach people, when we approach people, what training to give them, what resources we can provide to people. And we know that we need to improve and increase the data for the area, especially in terms of our inequalities. So that is something that we can run ahead with. A suggestion's been made that we can do the evidence work-based learning module from Macmillan, and we can focus that perhaps on cancer care reviews and inequalities. We'll continue our education plan, and we'll further develop our resources. We need to move into a position of being sustainable after the project ends. So having those resources out there, creating these networks who can support each other, so that information that's seeded can carry on. And we need to carry on with our collaboration attempts across the area. So what we want to see is an increase in our positive patient experiences in the area. We will see that from the National Cancer Patient Experience Survey, if that translates out to that. We do need better awareness of how inequalities impact CCRs, and we'll carry on with our collaboration across the services so it looks a bit more like a joined up picture. So that's it for me. Sorry, it's been a bit of a sort of flying through the slides there, but I just want to sort of get a feel for what people have. Anyone got any thoughts on that? Have they come across similar challenges? Are you doing something similar in your areas, and has it worked for you? Anything?
Thank you, Julia. It was brilliant and really